My code isn't working. Shh. Danny, what did you do? Go buy the grocery store?
Yeah, but she's just. Will be staying on the concrete, which I don't understand.
I don't
The
either.
ground will be a lot softer, but. They're both. Content. I wanted to get one for him mostly because. He's not being able to move. I figured it'll at least give him something to do. Am I overthinking this stuff?
Yeah, because he's been outside enjoying himself. He's. No, baby, I'm on camera. Oh, no, I'm not.
Professor Zeller, your sound's on.
Professor Zeller, you are now muted.
How do you feel?
Mm.
Hello. I have already pushed the grades to Canvas, so you should see your score in Canvas. So you can, nothing like being distracted while we talk about our new baby. Okay. Does anybody want to ask anything about the exam? Because since everyone has taken it, we can do that. If you're talking, I can't hear you. Is anybody talking?
The question about terbutaline.
Yes.
So it asked what you would monitor. Would you monitor maternal vital signs or uterine contraction?
Okay, good question. So why are we given terbutaline?
Typically, I feel like it's given for somebody who's going into preterm labor to help stop their labor.
Okay, okay. So yeah, you would sort of monitor the contractions, but what are some contraindications? What do you want to watch for? What would be a, huh?
Respiratory distress?
No,
Pulse.
who knows what a contraindication to terbutaline is? Well, a lot of you, I think, got it right. Do you remember? No? It's a beta adrenergic agonist. So it's going to increase the heart rate. It's going to increase the blood pressure. It's also a beta 2 agonist. So it's going to relax the bronchioles and it's going to relax the uterus. But when would you not want to give it to your client? Now, I know somebody knows the answer to this. What did you put for your answer?
For me, I picked uterine contractions, so I got it wrong.
Okay. Yeah, so you want to monitor the blood pressure. Okay.
That's what I thought, because I thought that was a blood pressure medication.
It's not a blood pressure medication. It's a medication for asthma. That it's used for asthma clients too. It's a really old drug.
Isn't that the one that raises the heart rate and the blood pressure?
Exactly. Mhm.
I need something to eat.
So you're not going to give it to your client if she has high blood pressure, heart disease, or maybe a heart rhythm issue, anything like that. You're going to question that order. Okay. All right. So let's talk about our newborn. So, you know, the placenta has been delivered. And we're going to give our client some bullets of oxytocin to help those blood vessels that are hanging out of the mother's uterine wall. They're exposed and they're bleeding. Okay. So we need that uterus to contract so those vessels will constrict and stop the bleeding from that area where the placenta was. Okay. So we want to see some involution. Okay. So right after that releases that placenta, it's like some of us are paying attention to the bleeding and others are more focused on the newborn. Okay. So cord delay the clamping of the umbilical cord. There's a new practice we have now that we usually delay it for about a minute. In other words, we're not going to clamp it. We're going to allow the blood to flow from the placenta to the newborn for the benefits of helping the newborn to have a little bit higher blood pressure. It helps divert anemia and things like that. So we're going to delay cord clamping. And we can put that baby on mother's chest for skin to skin. If newborns have difficulty adjusting to the extrauterine environment, it's usually a respiratory issue, it's not usually a heart issue. It's usually respiration. Okay, so there are two things that we're really focused on with this newborn. One is respiration. Does anybody have a clue what the other very important safety issue for a newborn is, as far as physiological safety?
Is it a temperature?
The what?
Temperature.
Temperature, yes, temperature. So our newborn cannot regulate its own temperature. This baby can't shiver, this baby can't sweat. So it's totally dependent upon us, the nurses, to make sure we're doing all the things that we know to do to keep that baby warm. Okay, so after the baby's born, when the head is born, we can go ahead and suction the mouth. Okay, this is a great time to suction the mouth. Baby is still being oxygenated by that placenta. Okay, when the head is out, the placenta is not pulled away yet, so we can take the advantage and suction that mouth, get all the extra fluid out, and then if we need to, suction the nose. So we're going to support that airway. All right. This is just an algorithm. If the newborn has some respiratory issues going on, your immediate assessment is hampered by respiratory issues. This is like an algorithm we call. Most newborn resuscitation is about positive pressure ventilation to help the alveoli to pop open. Just a little support. Just maybe a little oxygen, not a whole lot of oxygen, just more ventilatory support. You don't have to know the resuscitation. So let's talk about some signs and symptoms of respiratory distress. Let's see, before we get to that, let's just talk about this first. So signs and symptoms, if your newborn is showing signs of respiratory distress, some of the things that this baby's going to display are nasal flaring, retractions, muscle retractions, okay, between the ribs, at the lower, the subcostal, above the ribs, the muscle used to help the lungs, the chest wall expand. Those muscles are retracting because they are contracting. Okay, they're trying to pull up the chest wall. Okay, the baby might be grunting as he breathes, or you might hear some stridor, like a very musical sound. Croup is an example. So stridor is a sign of an upper airway obstruction. Okay, so there might be a lot of fluid in there still. Hypotonia. A sick baby, a baby having trouble with respiration is hypotonic. Their muscles are almost flaccid, okay, because all their energy is going towards respiration. And then you might notice if we don't intervene, the oxygen saturation drops, and then there might develop some central cyanosis. So the lips are kind of bluish. The oral membranes are kind of bluish color. So that's what we call a central cyanosis. And if we don't intervene, then the baby begins to turn blue all over because there's no more oxygen available. Acrocyanosis has nothing to do with respiration. Who can describe to me what acrocyanosis is, what you would notice, and then what would your intervention be? How would you resolve it? What do you think acrocyanosis means?
some blue extremities.
Yes, yeah, exactly. The hands and the feet
Hands
might
and
be
the
a
feet.
little blue, yeah, because the circulation to the extremities is still kind of immature. So we're just going to swaddle that baby. We're going to wrap that baby up. We can massage the hands and feet to try to improve that circulation, but that's just a sign of immaturity, immature perfusion. Has nothing to do with respiration, okay? So for a newborn, we want the respiratory rate to be between 30 and 60 breaths per minute, okay? 30 to 60 breaths per minute. Okay, sometimes those babies that have the extra fluid on board might have a faster rate as they're trying to get rid of that extra fluid. Okay, so they might have a temporary transient tachypnea. Okay, look for signs of respiratory distress. Make sure you do that. So what clients or what babies would you suspect to be at high risk to develop a distress?
Premature babies.
Definitely premature babies, because not enough surfactant, especially if it's before 35 weeks. Yeah, premature babies. Who else? Do you remember?
The
Babies
meconium
have
fluid ones.
Meconium.
Okay, one at a time here. Sabina, you go first.
The baby who passed meconium.
Okay, meconium aspiration, yes. And then Priscilla.
That's what I said was the meconium.
Okay, good. What else? There's one more you need to remember. What babies have trouble sometimes with respiratory distress?
Diabetics, hypoglycemias.
Okay, so mothers with diabetes during the pregnancy, if that glucose level remains high, that inhibits the production of surfactant in the fetus. Okay, so babies born to diabetic mothers definitely will have some respiratory distress. So we need to be a step ahead of that. Okay, good. It's normal for some babies to have periods of apnea where they're not breathing, as long as it's less than 20 seconds. Okay, that's always going to be an exam question. Okay. Apnea is not uncommon in a newborn because their respiratory system is still adjusting. So as long as it's not beyond 20 seconds, we're not that concerned. Just document if you see it. The seesaw respirations here up on the top, they're also called paradoxical. They're working oppositely. So ideally we want to see the chest and the abdomen expanding at the same time and exhaling and inhaling together. Okay. If you see seesaw respirations, that baby's in trouble. Okay. All right. So our baby is born, we're going to suction the mouth, and as the baby's delivered, the placenta is delivered. Wait a minute, clamp the cord. In the meantime, we're going to get that baby drying, and we're going to rub that baby. We're going to put that baby right on top of mom right away. Okay, immediately, skin to skin. And when we do that, when we place that baby on mother's chest, we can continue to rub the baby dry and put a warm blanket and a hat on the baby. If we do that immediately, that provides a lot of physiological stability. It helps the heart adjust, the pulmonary system. Okay, it's a great opportunity for breastfeeding because these babies, their reflexes are working. They know how to hunt for a breast. Okay, and bonding. Okay, so it's shown by research to really provide a lot of advantages for a newborn if we can get that baby on mother's chest. Okay. So how do we assess our newborn? We know that now we're getting ready to a normal newborn, no respiratory distress, so we can go ahead and put baby on mom. And then a minute after delivery, we're going to do our very first APGAR score. This is our tool we use to assess the status of our baby. Okay, to assess the adjustment the baby is going through to the extra uterine life. Okay, so we're going to look at 5 different areas, and they're called APGAR. The physician who came up with this instrument or this tool was name was Virginia APGAR. So we are using her name and we're adjusting the tool accordingly. So the A stands for appearance. What does your baby look like as far as color? Okay, so we're going to give score 2, 1, or 0. 2 is the best. So the total number we want for an APGAR score, perfect baby, would be a 10. Okay, 2 times 5 is 10. Okay, so first, let's look at appearance. Is the baby pink all over? Or at least good color all over? Okay, if it's a dark-skinned baby, you know, if you're familiar with dark-skinned babies, you know what a dark-skinned baby looks like when they're pink. Okay, so pink in the membranes. If we have a baby with some bluish or darker extremities, then we know we can only give a 1 because there's still a little prematurity in that circulation. Okay, if the baby is blue all over, then we give a 0. That's not a good sign. Okay, pulse. So what's the baby's heart rate? We do an apical pulse, very fast. So a baby's apical pulse at delivery could be 160 to 180 beats a minute. So if it is greater than 100, we're going to give 2 points. Okay. If it's less than 100, we're just going to give 1 point. And of course, if there's no heart rate, no heartbeat, then we're going to give 0. Grimace refers to reflex activity. Reflexes, like if you tried to lift the baby up off the bed, their little fingers will grab. Okay, the little palmar grasp. Or if you suction, the baby withdraws.
she did.
Pardon? You have a question?
Oh, sorry.
Oh, okay. So reflex activity, if a baby cries readily and pulls away from you when you try to do something, they have good reflexes. So we're going to give them a 2. But if they respond a little bit, but not much, in other words, they grimace a little bit, or they have a weak cry when you try to suction. Usually when you suction a baby, they don't like it. They'll withdraw, but sometimes they don't do a lot of withdrawal. So we're going to give them a 1. Okay, if they're not responding to any stimulation, we're going to give the 0. And then the second A is activity. Is your baby active? Okay, moving all extremities, extending and flexing all extremities. Okay, very active. So 2. Okay, if they're just doing a little movement, just a 1. And of course, no movement would be a 0. And then the R is respirations. Okay, good strong cry, no obvious distress. 2. If there's a little distress, or their respirations are super irregular, or they're slow, less than 30 breaths a minute, we're only going to give 1. Okay, if they're not breathing at all, it would be a 0. So we'd like to see a 7. Okay, a 7 to 10 is what we like to see. If you start dipping down below 7, 6, 5 is considered moderate distress. Okay, 3 is severe distress. Okay, so we do this 1 minute after delivery, and then we do it again at the 5th minute, right? So next week we're going to practice this. Okay, so we have our baby on mother's chest. Okay, skin to skin, baby's breastfeeding. Okay, baby's warm, got a hat on. Mom is singing to her newborn. So we know that the benefits of skin to skin, we talked about it, cardiopulmonary stability, temperature, preventing that baby from getting too cold, bonding and breastfeeding. We've done our APGARs. Baby's good. So we're just going to let mom and baby spend the time together for up to 2 hours. We don't need to do anything else for that baby for 2 hours. So we're monitoring the baby and the mother's interactions, that bond, that dyad relationship. Okay, so we're assessing mom's psychological status. And then we're also doing the physiological postpartum assessments that we do. So we're taking care of 2 clients, right? Okay. So once that 2 hours is winding down, then we do need to do eyes and thighs. Okay, this is the next priority. We need to put some erythromycin gel in the baby's eyes. Okay, at the lower conjunctiva, just a ribbon of it across. That will help destroy gonorrhea. Instilling the gel is usually a state law in just about every state. Now, yes, parents can refuse it, but you really need to be a good persuader, because yes, maybe mother doesn't have gonorrhea, but we don't know that for sure. So we just need to prophylactically treat the baby, okay, to prevent a blindness, because gonorrhea can cause a newborn blindness if we don't treat it. So we just treat every baby. So ophthalmia neonatorum or neonatorum conjunctivitis from gonorrhea. Now, chlamydia, which is a very common sexually transmitted disease, is not going to be destroyed by erythromycin. Chlamydia is not going to cause blindness either. It's going to spread rapidly in the tissues, and you'll see the effects of chlamydia about a week out after discharge. And the only way to treat chlamydia is with oral medications. Okay, the topical won't work. Okay, so we do the eyes and then we do the thigh. So we need an injection in that thigh, that vastus lateralis of that baby's thigh. Okay, so vitamin K. So why do we need to give vitamin K?
To prevent
What does,
Prevent crying.
to prevent what?
to prevent blood clot. It's
the
actually
other way
the
around.
opposite.
It's actually the opposite. Yeah, we want to prevent bleeding.
Oh yeah, sorry.
Okay, yeah, to prevent bleeding.
Yeah.
Okay. So the process of clotting requires factors in the blood. They're proteins in the blood that help clot, develop fibrin clots. Okay. In order for the liver to make prothrombin, one of the clotting factors, it has to have vitamin K. Vitamin K comes from intestines. It comes from the bacteria in your intestines. Okay. But you and I have bacteria in our intestines because we eat. But a newborn is not going to have any bacteria when he's born, not until he's been fed for a week. After about a week, then we find the bacteria, the normal bacteria in that newborn, and then it begins to make the vitamin K for the liver. Okay, so the history, the Jewish history, I only know about Jewish history. I don't know other histories of other countries or races or ethnicities, but I know for the Jewish people, usually circumcise their children, a cultural practice, a week out. This is what they used to do back before we knew vitamin K was what helped the liver to produce blood clotting factors. So the Jewish people would delay circumcising their baby boys for a week, because they knew if they did it too soon after delivery, the baby would bleed a lot. So they wait a week. And that's why, because the baby has to eat in order for bacteria to make the vitamin K. Okay. So vitamin K helps make prothrombin, and it also stimulates red blood cell development. And so it helps prevent any bleeding in the newborn. So that's eyes and thighs. Okay. So we do skin to skin. Okay. Do our Apgars. let bonding take place, let breastfeeding take place. Okay, baby is safe. Leave them alone, or at least monitor them, but let them have their time together. And then we can do the eyes and thighs. Okay. So when we talk about the thermogenic system, in other words, the ability of the body to generate heat. So genic means generate, thermo means heat. Okay. The ability of the newborn body to generate heat is limited because they can't shiver. Okay. So when a baby gets cold, they go through what's called a hypothermic stress. Okay. So increase muscle activity in order to try to produce heat uses up all their reserves. They don't have many reserves as far as energy reserves. You need energy to produce heat. Babies can go into an acidotic state very easily if they get cold. Okay. So how do we prevent heat loss in a newborn? Well, we talked about drying the baby off and putting a hat on. So let's think about that. You have a wet baby after delivery. How is heat pulled away from that newborn? If you don't dry the baby off, how does that baby lose heat?
Evaporation.
Evaporation, and you can see it on this slide here. Evaporation, it's at the very bottom. So when we're bathing a baby, we don't want to completely expose the baby when we're cleaning the baby, okay? We need to only expose the leg if we're washing the leg, okay? So think about that. Evaporation is one way that babies lose heat. Another way, we put the hat on the baby too, because sometimes even if the head is dry and the hair is dry, there might be a draft in the room. So that's what we call that convection. If you're familiar with a convection oven, you know, they have fans in them to move the heat around. Okay. So if you got a fan in the room or you have a window open, so you have draft in the room, that baby can lose heat from that. So it's called convection loss. Okay. And then conduction means actually conducting or contact. So when you get ready to weigh your baby, you don't want to put that warm body on a cold scale. They'll lose heat because that heat from the baby is being conducted to the scale. Okay, they lose heat. It's conduction. Okay, so we're going to put something down first, like a paper towel or maybe a receiving blanket, something that will protect the baby from that cold metal surface. Okay, and then radiation. If there is an object that is cold nearby, that'll draw heat from the baby. Something nearby. It's called radiation. It works the opposite too. If it's something that's really warm, like a heater, and you have baby nearby, they're gonna absorb more heat. They can get overheated. Okay, so that's radiation. And you need to understand those so that you know how to prevent cold stress in your newborn. Or you know how to reduce the increased risk that an older person has for hypothermia. It's the same thing. Okay. So the best ambient temperature, in other words, the temperature in a room where you have a newborn between 72 and 78 degrees is a good ambient temperature. Just put a sleeper on the baby and they should be comfortable. If it's lower than 72, you probably need another layer on that baby. Okay. Okay. So we don't do blood pressures on newborns. Maybe later on, but it's not important because there's usually not an issue with blood pressure. Okay, we're more respiratory focused. Okay, but if we have a newborn with persistent tachycardia, in other words, a heart rate above 160, this is after delivery and after an hour. Okay, because you might have a newborn with a heart rate of 170 within that first 30 minutes after delivery. Okay, especially if they're having some respiratory issues. Okay, but if it's persistent, if it continues above 160, then we're concerned about anemia, maybe, or hypovolemia, hyperthermia, sepsis. With sepsis, you're going to see a lower temperature. Okay, hypothermia. Persistent bradycardia. It's usually some kind of heart. This is a heart block issue or some kind of heart defect. So a baby's heart rate less than 80, we think there's something wrong with the heart at that point. Usually some kind of congenital malformation, tetralogy of Fallot, or an actual block, electrical block. Okay. Most heart defects can be attributed to rubella, substance use, a diabetic that had hyperglycemia in that first trimester, and then sometimes some prescribed drugs. Okay, so persistent tachycardia is a concern, and persistent bradycardia is a concern. So we want to see a heart rate, after delivery between 120 and 160. 120 and 160. Okay. So after baby spends a couple of hours with mom, okay, we're going to do the eyes and thighs, and we do need to do within that first, 6 hours or so, we need to do a head to toe. Okay. Usually after that 2 hours with mom, we need to take the baby and really do a good physical assessment, head to toe. Okay. So one thing we're looking at are reflexes. Okay. Reflexes, there's a lot of them. Okay. So sometimes in a newborn, you will see transient tremors. They kind of shake a little bit, and that's normal. Their nervous system is still a little bit immature. Okay. So some tone and some strength of their muscles should have some resistance to passive movement. In other words, if I lift a baby's arm up, they should resist it a little bit. That's just normal neurological behavior. Okay. But if they experienced a lot of hypoxia, they might have some neurological deficits. So you're going to see reduced reflex activity. Okay. So normal reflexes that you need to know: sucking and rooting. Have you ever seen the birth of a dog or a cat or a horse or a cow? Pigs, what do they do after they're delivered? They head right to that dinner plate we used to call, right to the teat. They know they have a rooting reflex and they have a sucking reflex intact. It's a low-level neurological ability. Okay, it's a reflex. So humans have the same thing. So when we place that baby on mother's chest, okay, when we place that baby on mother's chest, that baby will root. Okay, it'll root around for a nipple. In fact, if you just press on the side of their mouth, they'll turn their head as if to suck. Okay, and then they know how to suck. Okay, so that's basic reflex activity of a newborn. Grasping, that's when they if you put your fingers in, they just curl their little fingers around. Okay, we want to see grasping fingers and toes. So a palmar grasp, and then the feet would be a plantar grasp. Okay. The Moro reflex is another one. It's a startle reflex. Have you ever seen one? A baby that's startled, they actually their arms will go out forward as if they're going to get ready to hug a tree. Okay, they're startled. Tonic neck is called a fencing movement, where one arm is up behind the head like this, and the head is turned in the opposite direction, and then they have this arm, okay, reaching forward. It's called a fencing. Tonic neck. The stepping, and then the Babinski. The Babinski, we talked about it in health assessment, when we do a neurological assessment on a client we think has brain damage, we'll try to elicit the Babinski, which is if we take the foot and we rub against the lateral portion and come up underneath the toes, a Babinski reflex is going to cause the fanning of the toes. So that's a positive Babinski. And that's normal in a newborn. Okay, that's normal. But if we don't have that reflex response and we palpate, we're what are we calling that? Rubbing up the side and across and the toes curl in, that's a negative Babinski, and that's what we should see in an adult. Okay, so if you have an adult with a neurological damage, really severe damage, you're going to see a Babinski because there's been damage. Okay, so that's the Babinski.
So do we need to know like how these, like what is a Moro and how does that look like?
Yeah, you don't need to know the tonic neck, but the rest of them you need to be familiar with.
Okay.
There's some great pictures in your book. Yeah, pictures do a lot for things like this, so you can look at those. So heart rate between 120 and 160. Like I said, you don't need to memorize the blood pressure or anything like that, or the head circumference. You need to know the heart rate, 120 to 160, and temperature at least 37 or 36.5. Okay. Respirations between 30 and 60. Okay. Usually the head measures larger than the chest. But you don't have to know that you don't have to know the numbers. So if you have a client that you're taking care of, 1 hour ago, he was delivered and you're going in to see how baby's doing. And his name's Jones. He's a full-term baby. He's been spending skin-to-skin time with his mother, and he's been breastfeeding. And when you assess him, his respirations are 40 breaths a minute. His temperature is 96.2. There is some acrocyanosis present, heart rate 125. There's some scrotal edema. His arms and his legs are flexed, and the Moro reflex is absent. So which one of these is the most important priority that you need to intervene? Which one is your priority? You need to follow up with this. Which is the first one?
Temperature.
Okay, I could see that. It's a little low. Anybody else have? What else is something you really need to address? What do you think?
Scrotal edema.
Okay, we certainly need to address scrotal edema. It's not uncommon, especially if there was a troublesome labor. What else?
The moral reflex is absent.
Yeah, so if you have an absent reflex, what would you do as a nurse when you're doing this assessment and you notice you slap your hands together, baby doesn't respond? What would you do?
Hearing screen.
Okay, might be a hearing issue. So what would you do, Sabina?
I don't know what they do hearing.
Well, Sabina, you've had enough OB. If I put you in to follow a nurse and she said, go ahead and do a quick assessment on that baby, Sabina. And you found all these things and you noticed that there was no moral reflex. What would you do?
I will just let the doctor know.
Yeah, there's nothing as a nurse you can do.
Right.
You would certainly need to let the provider know. Yeah, it might be a hearing. issue, okay? And that probably is what it is, because everything else looks pretty good. Now, we need to address the temperature. So addressing the temperature, we need to include client education, okay? Keep the hat on, keep the baby covered, clothes, that sort of thing. Acrocyanosis, can you teach mom about acrocyanosis? She might be concerned. So would you teach her something? Would you explain something or tell her what she needs to do?
Like just massage and swaddle.
Yeah. So, mothers, especially if it's a first time mother, she doesn't know. She might be fearful. You need to just reassure her it's not uncommon. We just need just his immature perfusion, and you probably won't use those words. Scrotal edema. How do you assess scrotal edema? How would you assess that? You observe it in your inspection. Do you know what you would do next step as far as assessment? We talked a little bit about this in health assessment, if you remember.
Is that the like the I don't never mind, nothing.
Go ahead, Annie. Go ahead. You're muted.
I want to
now.
say like through the fingers, but that's like how to hold it, but that's not the answer.
Okay. Yeah.
I'm sorry.
No, don't be sorry. No, you need to think. You need to just talk and think. It's good. Anybody know? What if you had an adult client?
So it's just like you put your thumb and scroll down.
Yes, that's what I'm trying to get to, how to hold it, but I don't know if that's what you asked.
Okay, so you're going to palpate. You
Yeah.
might palpate, but even before you palpate, do you know what you could do to see maybe what might be causing the edema? You could actually shine, remember transillumination? Shining a light through it, make sure there's no
yes.
mass in there. Yeah, you can do transillumination just as part of your assessment. Okay, good job. All right. So which of the following describe the benefit of skin to skin? Why is it so promoted? Even if a mother's not breastfeeding, skin to skin is good because of what?
The body temperature.
So temperature regulation.
It's really important in bonding.
Bonding. Yeah, even if mom is not breastfeeding. So cardiopulmonary stability. Okay. Positive bonding, but it certainly doesn't decrease the need for breastfeeding or some kind of feeding, right? And we don't want it to lower blood glucose, and it really doesn't do that, okay? But certainly temperature and bonding and the other stability factors. Okay. So integumentary, these are the terms that you need to be familiar with, and I would recommend that we look at pictures. Okay, look at pictures. So let's recognize some of these pictures. H is just a fella with a special haircut or a coiffure. Now, I think that's so cute. I just had to put that in there. Okay, so let's talk about these. Okay, so over here, A. What is A? Anybody know what this picture is? Right there.
Vernix.
Vernix.
It looks like
Vernix.
Vernix, yeah.
Vernix caseosa. That's right. That cheesy substance. That cheesy substance helps keep the baby warm too. Okay. It has some antimicrobial activity, keeps the skin moist. So we don't want to rub it completely off at first. Okay. What about B up here at the top?
Is Amelia?
Melia, yes. Those are those immature sweat glands. Okay. And then what about C?
I've heard it called a stork something before, but I don't know the technical term.
Yeah, it is a stork bite. But the medical term for that is simplex nevus. Simplex nevus. It's temporary. Okay, it's temporary. It will fade. What about D? Do you know what I'm trying to communicate with D?
A newborn probably shouldn't be on their belly unless they're doing tummy time and they're being observed.
So I'm not sure I understood that, Miranda.
Sorry, I'm in a classroom full of people.
Oh.
So newborns should do tummy time, as long as they're being observed by mom, but I don't see any skin conditions that stick out to me.
Okay. There's a little, do you see the little fuzziness on his skin? It's called
I heard
lanugo.
that-
Lanugo?
Yeah, it's
Lanugo?
called
Hair,
lanugo.
yeah.
And it's really fine hair. And we usually see this on a preterm baby. Lanugo. Okay. And then down here, F is what?
Is that Mongolian spots?
Mongolian spots. So they're permanent, but they tend to fade. And you'll see these on darker skinned people. Okay, what about E? What is that?
Is the Moro reflex?
That's the Moro reflex. Yeah, there's no skin issues here, but that's the Moro reflex. See how the arms come out? Startle reflex. Okay. And then G, what reflex is that?
Babinski?
Babinski. So that's good. Baby has Babinski reflex. And then H.
Normal happy baby?
Normal happy baby. Yeah. You can see the ointment on the eyes. What else do you see in that picture?
Well, on H, it's two H's. The one with the ointment on the eyes, it look like that's acrocyanosis.
Exactly, passion. Yeah. So the hands and the feet are a little blue. Yeah, a little bit. And then I, does anybody know what that is? It's a rash. So like a little pinpoint rash. It's not a very good picture. It almost looks like petechiae, but that's not what I meant for it to be. This one's probably one you don't know. This is called just a generalized rash with macules, flat redder areas, and little pimple type things, papules. Okay. It's called erythema toxicum. It sounds awful. It's not toxic. It's just one of those things that occurs. The baby is not uncomfortable. It's not pruritic. It's not anything that's going to hurt anybody. And it resolves on its own. Okay. It's called erythema toxicum. So in this situation, we just have to explain to mom, don't panic. Okay. This is a normal baby rash. It'll go away. Okay. And then J.
It looks like jaundice.
Jaundice. Yeah. So what causes jaundice?
Hypoalbuminemia.
So bilirubin levels
Bilirubin.
are high. Bilirubin. Yeah. Bilirubin is the breakdown of a red blood cell, right? And usually babies have a lot of red blood cells when they're born, especially when we delay cord clamping. They have a lot of extra. So they're going to have some hemolysis going on, and they're going to be a little jaundiced. Okay. The liver isn't mature enough to conjugate it with a protein yet. So we have to feed this baby and make him go poop. Okay. To put it simply, he needs to, and that's what breastfeeding is really good for this. Okay. Okay, good. Jaundice. So some of the things, and we're going to talk about next week, we're going to go over a lot of these things again, because we're going to take a baby that's had injuries or a high-risk baby, what's going on. So the normal today is it's normal, typical to see some molding of a newborn head, because the areas, the temporal bone, the parietal bone of the skull, the occipital bone, they're not really together. Okay, they have to be aligned, but there's a division between them. They're called sutures, so that during delivery they kind of overlap a little bit to allow the baby to navigate that birth canal. Okay, so sometimes the molding takes place. So you might have a misshaped head. Okay, so molding is normal. Okay, kaput, we call it kaput. It's just collection of fluid all over the baby's head. Okay, this is just during delivery. The blood vessels might in the soft tissue on top of the bone might be damaged, and then they tend to collect fluid. So it's almost like an edema. Okay, it's called a kaput. It's resolved in a few days. So you have to tell mom that. Okay, and then this next one over is called a cephalohematoma. Now this is a little deeper. We've talked about hematomas before, bleeding, and it's usually from some kind of traumatic birth injury. But the difference between this kaput and the cephala is that the cephalohematoma is just localized. It doesn't spread across the sutures of the skull. It's just localized in one area, and it can be a little firm. So it's bleeding. Okay. Usually these do resolve on their own. Okay. But in these babies, you're going to see some bilirubin levels increase a little bit. So this baby probably will experience a little bit of jaundice. Okay. With the cephalohematoma. Okay. So the fontanelles are the area where the juncture of those bone segments. Okay. We can actually use those part of our assessment. So we're going to palpate those. If it's bulging, we're concerned about intracranial bleeding or something. If it's depressed, we're going to be concerned about dehydration. Okay. All right. Let's see, what else do we have? The immune system. So baby receives IgG, which is a major immunoglobulin from mother during the pregnancy. Okay. So, and it usually protects the baby for 3 months after delivery. But even so, a newborn is still susceptible to infections with delivery. Okay. I always educated my clients, don't take your baby out for at least 6 weeks. And that was before COVID. Okay. So COVID changes things. You really need not to take that baby out in crowds. I wouldn't even want that baby out in crowds at 6 months. Okay. If at all possible. Okay. I was traveling with my husband in New York just for a quick weekend to go watch Phantom of the Opera. And, you know, New York is very, very crowded, people everywhere. And there was this couple, they had 2 children. They had one in a stroller, and they were carrying a new baby. Looked like that baby wasn't a month old, wasn't 4 weeks old yet. No hat. It wasn't that warm out. That baby was exposed to germs and everything else from all those other people, and then the risk of getting cold. So that wasn't very wise. I really wanted to stop him and tell him, you know, but you don't do that in New York. Okay, so the benefit of newborn, that's breastfeeding. Okay. IgA is another immunoglobulin. So immunoglobulins are like antibodies. Okay. They're part of our immune system. They protect us. So breast milk has IgA in it, and IgA helps to neutralize, in other words, destroy bacteria and even some viruses. So that's a huge benefit for breastfed babies. Okay. Breastfed babies also have reduced risk for respiratory problems, for becoming a diabetic, for anti-inflammatory issues. And so there's a lot of benefit to breastfeeding. Breastfeeding also enhances, when we give a vaccine, a hepatitis B vaccine to a newborn, if they're being breastfed, that vaccine has more chance of being very effective, okay? Better antibody response, okay? The fetus already produces its own IgM, which is another antibody that fights bloodborne pathogens, okay? So that's about the immune system with breastfeeding. It's called passive immunity, okay? Because we're not injecting it. So in your assessment of your newborn, I'm just going to continue. We just have a few more minutes. In your assessment, your baby's stable, been skin to skin with mom. You've done the eyes and thighs, and you're assessing and you're teaching mom. You're watching their bonding, making sure mom's not developing any postpartum blues that you have to discuss with her or help her with. So you're doing a complete head to toe. You want to look, of course, you're going to do the cardiac assessment too. You're going to listen to the heart, listen for murmurs, find where the PMI of a newborn is more centralized. The heart is a little higher up and more centralized. So you're going to listen to the heart really well. And then you're going to observe the abdomen. So remember your health assessment skills. Inspection is first, palpation is next. Actually, inspection for the abdomen, inspection, and then auscultation, and then palpation. Okay, so observe the abdomen. Does it look distended? Look at the umbilical cord. Is it, look at it. Of course, you might not be able to see it super well, but you should look for the number of vessels. Are there 2 arteries and 1 vein? You should still be able to see that in the hospital. Okay. Contour. Okay. Auscultate those vowel sounds. Next week, we're going to be talking about something called necrotizing enterocolitis in a newborn. And in that case, the baby's abdomen is going to be distended. You're going to have hypoactive vowel sounds. There's going to be a lot of tympany when you percuss on that baby's belly. Normal spitting up versus projectile vomiting. Okay. We need to explain to moms that it's normal for a newborn to spit up. They have small stomachs to begin with. But if they're sitting up and they just throw up and it goes across the room, a projectile, that we're concerned more about some kind of mechanical or some kind of anatomical problem with the esophagus, the stomach, or the pylorus, okay, achalasia or something like that, okay? You need to assess the ability of the baby's latching, okay? Is the baby latching well, okay? Observe for feeding cues. I gave you, I just posted it in week 8 for next week, nutrition PowerPoint, and it talks about latching, and it talks about what are some behaviors you'd see in that baby. That baby's hungry, so they're looking around, they act, they're kind of restless. Those are cues of I'm ready to eat. Okay, so we need to be able to observe those things and teach mom. Okay, we've talked about the gut already. And then bilirubin. We'll finish up with bilirubin. Bilirubin, if a baby is born with jaundice, it's a problem. It's pathologic. Okay, pathologic is a problem. And if your baby is born with jaundice, something's been going on during the pregnancy that's caused bleeding. Okay, the baby's anemic. The baby's been bleeding during the pregnancy. Okay, and so they're born with jaundice, a lot of bilirubin, and the liver certainly can't conjugate it. Okay, so pathological is abnormal. It has to do with blood incompatibility, either the type of blood or the Rh factor or some other antibody in the blood. Okay, but normal physiologic jaundice can occur 3 to 5 days later, okay, or breastfeeding jaundice. Just the baby not maybe breastfeeding enough, they get a little jaundice because bilirubin has to pass through the stool. Okay, if baby's not eating much, it's not passing through the stool. Okay, we'll talk more about bilirubin later. Okay, but bilirubin levels that climb are not good because it can actually damage the brain. Okay, so we have to figure out what we need to do. So we feed, and if we have to, we put them under an ultraviolet light to help that bilirubin be conjugated. It's a chemical change of the bilirubin that allows it to be passed through the stool. Okay. I think that's everything in my slide. Oh, no. So this is just a picture of bilirubin. So take some time to look at it. Sometimes looking at a picture helps you to understand what's going on. Okay. All right. I think that's it. All right. Good. So we touched on the newborn. So next week we'll cover a lot of the same things because we want to compare normal with abnormal. We're going to talk about injuries to a baby during labor or during the delivery. We're going to talk about infections and what would you see in a newborn who's developing or has an evolving infection. We're going to talk about torch infections and things like that. And then preterm babies. We're going to go more into preterm babies. So I'm working on a brand new PowerPoint. So I haven't given it to you yet for high risk, but I'll finish it and you'll have it by Sunday. I like the newborn. I think it's fun. So I will get that new PowerPoint to you and then we can kind of put things together. Okay. So you have your grades for your exam. The homework is still calculated in. So the end of next week, I will take your homework off and you'll see what your KGA is, which is just your quizzes and your homework. Okay. And your exams. I'm sorry, just your exams and your quizzes. Okay. So work on your discussion for this week, finish it up. And then you have, don't you have preterm, something preterm baby to work on? Okay. Okay. All right. So if you didn't get stuff done from last week, can work on them and get them in. Okay. By Sunday night, so you can get credit for them. Okay.
I have a
All right.
Quiz next week.
Pardon?
Go,
What'd you
Brandon.
say?
Do you know when the signups are going to open for the HESI?
No, I don't, Brandon. And it depends. What campus are you from?
Columbus.
Columbus. Do they use ProctorU? Do you know?
No, they use.
You go on campus then?
Yeah.
Okay. No, I don't know, but I'll let you know as soon as I get that information. Okay.
Okay. Thank you.
You're welcome. So those of you who are on a campus now, and I don't have the list of campuses that uses ProctorU, you have to go through training to be able to use ProctorU. It's very strict. So if you got an email about training, make sure you sign up for a training. There's some going on this weekend, tomorrow and Sunday. So you have to go through training. And what we do in the training, we tell you what ProctorU does. We check your computer to make sure it's compatible with ProctorU and the HESI. Okay. All right.
Quiz next week.
Quiz next week, quiz 5. Yes. It's
And
the very last quiz.
yeah, whatever the PowerPoints you did today from till 19, does those have all the answers for quiz or do we need to go through all of them?
Yes, the PowerPoints from this week. And then, 2 of the questions will be from next week.
Okay.
And then there'll be a math.
So are we doing at the very end quiz?
No, we're going to do it at the beginning of class like we always do.
So you said the 2 question will be from the next one. So how are we going?
I meant 2 of the questions will be from next week, the high risk OB.
Okay. So can you send us these slides?
I already sent them to you.
Okay, okay, perfect. Thank you.
It's under week 8.
Week 8. Okay, thank you so
And
much.
then next week, remember, you've got your exam study sessions that we do, because you have your next exam in week 9.
9, right?
A busy week.
Yes.
Yeah, it's going so fast now.
Great, thank
Okay,
you.
it's going so fast. Okay, so I can tell you, the last exam you take, of course, it's not going to have any week 9 content on it. Okay, you'll take it in week 9, but the week 9 content is about contraception, infertility issues. There might be 1 or 2 questions on the HASI from it. Okay,
Okay.
so we talk about that week 9.
Exam
Alright.
3 is in week 10, correct?
No, it's in week 9.
Thank you. I'm sorry.
Week
thanks.
10. So week 10, what we're doing is we're just
HASI.
preparing for the HASI. Okay, no new content. We're just preparing for the HASI in week 11.
Okay, thank you.
You're welcome.
Thank you so much.
I'm sorry, are we dismissed?
You are.
Thank
Good night.
you.
You
Thank-
are dismissed.
Thank you.
You're welcome, Joy T.
Thank you, Dr. Miller.
You're welcome. You're welcome. You did great.
Thank
So
you.
well. My
Thank
goodness.
you.
You did really well on your exam. I mean, you couldn't do any better, could you?
I couldn't have done it without you.
Ah, that's nice. Well, you've been really working hard.
Thank you.
I'm so happy for you.
I'm gonna be in all the next weeks.
Yep. Yep.
Thank you. Enjoy your
Okay.
weekend.
You too, Malian.
Bye.
Bye-bye.